So, madam, we are live now. Shall we start?
Yeah.
So, good evening, doctors and all the participants. Shuman on behalf of Shield Healthcare, welcome you all in today's another very interesting and important topic, that is intrauterine growth retardation. And our guest speaker is Dr. Bala Guhan, madam. Madam is the senior consultant, Department of Obstetrics and Gynecology, Kozhikode District Cooperative Hospital, Iranipura. So, with this short introduction, I request madam to take over the session, and meanwhile, I request all the participants for your active participation, and please post your queries on the QA dashboard of the Sheet Connect page. So once the talk will be over, we shall have a short discussion on this topic with madam. So thank you very much, madam, for your valuable time on our digital platform Sheet Connect, and over to you, madam, for further postings. Thank you very much.
Thank you. Thank you very much, Dr. Suman. Thank you for the introduction. And I think we will straight away go on to the discussion on intrauterine growth restriction. Got it? No, chat. So, as we all know, intrauterine growth restriction has been defined as a rate of fetal growth less than the normal in the light of growth potential of a specific, that is specific for a particular infant as per the race and genetic makeup, or a deviation from or a reduction in an expected fetal growth pattern. Sorry for that. Or a deviation from or a reduction in the expected fetal growth pattern, and is usually as a result of innate reduced growth potential, or because of multiple toxic adverse effects on the fetus. It can occur in a preterm, term, or postterm babies. And as we know, mild IUGR defines disparity of less than 2 weeks, and severe IUGR when there is a disparity of more than 4 weeks of gestation. Slide the incidence of IUGR is 6 times higher in an underdeveloped or developing country. As we know, it is 75% more in the Asian countries, and countries like Bangladesh, India, Pakistan, Sri Lanka, Cambodia, Vietnam, Philippines, Indonesia, Malaysia, Thailand, and People's Republic of China. We have the highest incidence of low birth weight and IUGR babies among the Asian countries. So according to the nomenclature, the small for gestational age and IUGR babies are too often considered synonymously, but there is with a slight degree of overlap. SGA fetuses are not necessarily growth restricted, but they may be constitutionally small babies and not at very high risk. With the late onset of pathological cessation of growth, such babies may have typical features of IUGR, and there is increased perinatal and perinatal mortality and morbidity. As we know, up to 16 weeks, cellular hyperplasia is what predominates, and following that, like about 16 to 32 weeks, between 16 to 32 weeks, we have hyperplasia and hypertrophy of the cells, fetal cells. And after 32 weeks, it's more of hypertrophy. So most of the fetal gain, at least 2/3, occurs in the late trimester, that is beyond 24 weeks. And we have several types of growth restriction. Fetuses who are small but healthy belong to the symmetrical type, and the birth weight is less than 10 percentile for the gestation age. They have normal pondral index and normal subcutaneous fat, usually an uneventful neonatal course. Fetuses where growth restriction occurs by pathological process is true intrauterine growth restriction. Depending on the relative size of the head, abdomen, femur, they are subdivided into symmetrical or asymmetrical types. So symmetrical is about 20% of the growth restricted cases, and affects from the noxious and is actually occurring due to the noxious effects occurring in the early phase of cellular hyperplasia. But the total number of cells is less compared to the normal baby. Most often caused by structural or chromosomal anomalies and congenital torch infections usually. Pathological process is usually intrinsic to the fetus and involves all the organs, including the brain. The asymmetrical IUGR, which accounts for about 80%, is usually affected in the later months of pregnancy, but during the cellular hypertrophy, the total number of cells remain the same, but smaller in size. The pathological process is often maternal disease extrinsic to the fetus. For example, as we know, pregnancy-induced hypertension is one important one among them. Diseases alter fetal size by reducing the uteroplacental flow and or by restricting oxygen supply on the nutrient transfer, or by reducing placental size. Preferential shunting of oxygen and nutrients to the brain occurs in such cases. And here, as we know, as we can see, the first picture shows the appropriate growth profile of a baby. And the second one is the symmetrical IUGR, where which is about 20 to 30% of the cases. And there's typically early onset, less than 32 weeks of gestation, with a normal pondral index, reduced abdominal circumference and head circumference. Whereas in the last one, we can see that the asymmetric IUGR, which accounts for about 70 to 80%, occurs more later than 32 weeks of gestation, with decreased pondral index and increased ratio of the head C to AC, that's with a brain sparing effect. It's mainly caused by chronic hypoxia, malnutrition, etc. So coming to the etiology, maternal causes may be constitutional. Small women, maternal genetic and racial background is an important factor. Such babies are not at increased risk. Pre-pregnancy weight less than 1,000 pounds gives a twofold increase in causation of IUGR. Reduced intrauterine growth of the mother is a high risk factor. Maternal nutrition before and during pregnancy is very, very important. So that implies the importance of adequate maternal nutrition during pregnancy. Glucose, amino acids, and oxygen are deficient. When gets deficient during pregnancy can lead to growth restriction. Social deprivation, effects of associated lifestyle factors such as smoking, alcohol, substance abuse, and poor nutrition can also occur. All these can lead to growth restriction. Maternal diseases, anemia, sickle cell disease, hereditary anemias, hypertension, thrombotic disease, heart disease, chronic renal disease, collagen vascular disease, toxins, as we know, alcohol, smoking, cocaine, all the drug abuse substances, heroin, and other drugs. Another important thing that we have to bear in mind is the antiphospholipid antibody syndrome, especially in cases of recurrent pregnancy wastage and growth restriction. We have to check into the anti-cardiolipin antibodies and the lupus anticoagulum. Maternal placental aggregation and placental thrombosis, the main pathology. And of course, extrauterine pregnancy. Fetal factors in which the substrate or the nutrients is not properly utilized by the fetus, maybe due to structural anomalies, cardiovascular, renal, etc. Chromosomal anomalies in about 8 to 12% of the growth retarded fetus. Triploidy, aneuploidy, trisomies 13, 18, 21, Turner syndrome, disorders of bone cartilage, osteogenesis imperfecta, chondrodystrophies, etc. As we know, infections of which torch, malaria are important. Cytomegalovirus has a direct cytolysis and loss of cell functions. Rubella causes vascular insufficiency by damaging the endothelium or small vessels and reduces cell division. Hepatitis A, B, listeriosis, tuberculosis, and syphilis. And with syphilis, the placenta is, we have hyperplacentosis, paradoxically. There is increase in weight and size of the placenta due to edema and perivascular inflammation, paradoxically in syphilis actually. And also in multiple pregnancy, we have hyperplacentosis, obviously due to the increased size that the demand for both the babies. Mechanical hindrance to growth and excessive fetal demand, chronic hypoxia, high altitude, maternal cyanotic heart disease are other factors. Now, the placental factor, which includes the poor uterine blood flow to the placental site for a prolonged time. This leads to chronic placental insufficiency with an inadequate substrate transfer. As we know, babies obtain their nutrition through the placental flow. So it is very important that adequate placental flow be maintained. In cases of placenta previa, abruption, circumambulate placenta infarction and mosaicism, there is reduced flow, and hence transfer of adequate amounts of nutrients and oxygenation occurs. Transfer of adequate nutrients does not occur in such cases. And in about unknown cases, around 40%, we encounter growth restriction. So the main pathophysiology is reduced availability of nutrients in the mother, reduced transfer by placenta to the fetus, and reduced utilization by the fetus. The brain size, as well as cell number, are reduced. Liver glycogen content is reduced. Renal and pulmonary contribution to amniotic fluid are diminished due to reduced blood flow. There is reduced volume of liquor, which is called oligoamnios, and the risk of intrauterine hypoxia and acidosis, and death if severe. In growth-restricted fetuses, there is accelerated lung maturity. The pulmonary functions are accelerated, and the fetus responds to a stressed environment by increased adrenal glucocorticoid secretion, which leads to accelerated fetal lung maturation. So coming to the diagnosis, first of all, clinically, palpation of the uterus, of which fundal height, like a volume, fetal mass has to be assessed. Symphysiofundal height is very important parameter for fetal monitoring and closely relates with the gestational age after 24 weeks. A lag of 4 centimeter or more should give us the thought to intrauterine restriction, and it's fairly sensitive, about 30 to 80% sensitive. And serial measurement is very important. Maternal weight gain being stationary or falling during the second half should be cautioned, and abdomen girth, stationary or falling, should be looked into. So you have a battery of investigations, for example, your hemoglobin counts, the blood group, sugar, urine examinations to rule out possibility of preeclampsia, and all the infections and the diabetic screening. So coming to the biophysical profile, the first examination at 16 to 20 weeks should confirm gestational age and anomalies. So we have the anomaly scan. Currently, we go for the first anomaly scan. As we know, it's around 3 weeks of 3 months. It's 12 weeks of gestation. We have the NT scan followed by the anomaly scan at around 20 weeks. And if there is any problem detected, we have to go for 2 to 3 weekly ultrasounds to keep monitoring such fetuses. Head circumference and abdomen circumference ratios. So less than 1 before 32 weeks. It's when equal to 1 between 32 to 34 weeks. Sorry, more than 1 before 32 weeks, equal to 1 between 32 to 34 weeks, and less than 1 after 34 weeks. And elevated asymmetrical IUGR, normal asymmetrical IUGR. We have 85% IUGR fetuses detected, and AC is the single most sensitive parameter here. Serial measurement of AC and estimation of fetal weight are more diagnostic. Female length not affected in asymmetric IUGR because the growth restriction occurs later after 32 weeks. So FL by AC is equal to 22 from 21 weeks to term, and FL by AC is more than 23.5 in IUGR cases. So amniotic fluid, the vertical pocket of amniotic fluid is less than 1 centimeter, which suggests growth restriction. The 4-quadrant technique that's usually done in the assessment of amniotic fluid index, and usually the AFI about 5 to 25 is considered as normal, and AFI is, if less than 5, should go with caution of oligoamnios, and the causes of oligoamnios should be looked into. Anatomical survey to exclude fetal abnormalities, and biparietal diameter should be checked. Placental grading is usually done. Grade 0 placenta is usually grade 0 less than 18 weeks, which shows uniform echogenicity and smooth chorionic plate. Between 18 and 29 weeks, we have the grade 1 placenta, which is occasionally parenchymal with occasional parenchymal calcifications and hyperechoic areas. Grade 2 comes after 30 weeks. the occasional basal calcification and hyperechoric areas, and may also have coma-type densities at the chorionic plate. Grade 3 placenta is when it's mature more than 39 weeks, and significant basal calcifications can be seen with chorionic plate interrupted by indentations. On early progression to a grade 3 placenta, it's sometimes associated with placental insufficiency, which means earlier occurrence of grade 3 placenta is suggestive of a placental insufficiency, which is detrimental for the baby growth. So grade 3 placenta, which is usually seen towards late term, that is 39 weeks, should not happen earlier and should be looked with caution if occurs earlier. So we have certain ultrasound Doppler parameters. Doppler velocimetry, elevated uterine artery SB ratio with more than 2.6. Presence of diastolic notch. Diastolic notch suggests incomplete invasion of placental trophoblasts to the uterine spiral arteries, which normally occurs around 11 weeks. By around 11 to 14 weeks, the invasion, the trophoblastic invasion is complete, so as to allow proper placental flow and have low resistance blood flow in the placental tissue. So the diastolic notch is suggestive of incomplete invasion of the placental trophoblasts. Also predicts possible development of preeclampsia. Normally, diastolic flow increases as pregnancy progresses. Reduced, absent, reversed diastolic flow in an umbilical artery indicates fetal jeopardy and poor perinatal outcome. So here we can see the normal flow velocity waveform from the uterine artery at about 22 weeks of gestation. And the second figure, we can see the notching. Flow velocity waveform from the uterine artery at 24 weeks in a pregnancy with impaired placentation. And here we can see early diastolic notching, the yellow arrow there, and late diastolic, there is decreased flow, which is delineated by the orange arrow. So there is decreased late diastolic flow. Both are obvious. These are different patterns of the umbilical artery Doppler velocimetry. The first one is normal. The second one, there is absent flow, absent diastolic flow with a high placental vascular resistance. And the third one shows reversal of flow, which is very ominous and may precede fetal demise. This is the waveform of the middle cerebral artery with increased diastolic flow in the brain, suggesting fetal brain sparing, showing fetal brain sparing effect, whereby the fetal cerebral cells, vessels open up, and thereby there is decreased cerebral vascular resistance to allow increased blood flow to the brain, thus diverting the blood to the important organs in the state of hypoxia. So the brain sparing effect shows that the baby is compromised and hypoxic. This is the Doppler spectral waveform of ductus venosus, shows not just absent diastolic flow, but actual reversal during diastole, which is also an ominous sign. Elevated levels of maternal serum alpha fetoprotein and high HCG level in the second trimester are markers of abnormal placentation and risk for the weight deficit of 600 gram, below the minimum in percentile standard. Length usually unaffected. Head circumference relatively larger than the body in asymmetric IUGR. Baby is usually alert, active, with normal cry, eyes are open, and the reflexes are usually normal. So the complications, antenatal chronic fetal distress, fetal death, diminished amniotic fluid volume or oligoamnios with a increased likelihood for cord compression due to oligoamnios, intranatal hypoxia, acidosis. After birth or immediate complications, we have late complications. The immediate complications are asphyxia, bronchopulmonary dysplasia, RDS, hypoglycemia, meconium aspiration syndrome, microcoagulation leading to DIC, hypothermia, pulmonary hemorrhage, polycythemia anemia, thrombocytopenia, hyperviscosity syndrome, necrotizing enterocolitis due to reduced flow in the intestinal tissues, intraventricular hemorrhage, electrolyte abnormalities, hypophosphatemia, hypokalemia due to impaired renal function, multi-organ failure. There is increased perinatal mortality and morbidity. The late complications include in symmetrical IUGR babies, they have retarded neurological and intellectual development in infancy, catch-up growth, asymmetrical catch-up growth in early infancy. The worst prognosis, there is worse prognosis with congenital infections, congenital abnormalities, and chromosomal defects. There is increased risk for metabolic syndrome in adult life, like obesity, hypertension, diabetes, and coronary heart disease. Altered orexigenic mechanism that causes increased appetite and reduced satiety. Reduced number of nephrons, lead to renal vascular hypertension. Per se, IUGR does not cause any harm to the mother. Underlying disease process like preeclampsia, heart disease, malnutrition may be life-threatening, but IUGR per se does not cause any maternal complications. The risk of having another growth retarded fetus is twofold. That is, if you have an IUGR baby during this pregnancy, you have a twofold risk in having the same problem in the coming pregnancy as well. The immediate neonatal mortality is 6 times more than normal newborn babies, or even similar weight appropriate to the shorter gestation age. Most babies die within 24 hours and morbidity rises up to 50%. So management of such cases, constitutionally small babies, there is no intervention needed. Asymmetric IUGR babies are investigated for anomalies, infections, and genetic syndromes. There is actually no effective therapy. Placental disease or reduction in placental blood flow may be checked into and tried correction. So there is no proven therapy for reversing IUGR once it is established. Adequate bed rest, specifically onto the left lateral position. I'm sure we all know why. Correct malnutrition by balanced diet with an extra of 300 extra calories per day. Appropriate therapy for complicating factors which are likely to produce intrauterine growth restriction. Avoidance of substance abuse, especially smoking, alcohol, and other substance abuse. maternal hyperoxygenation, the rate of 2.5 ml per minute by using nasal prongs for a short-term prolongation of pregnancy. Low-dose aspirin, 50 milligram per day in selected cases in a history of thrombotic disease, hypertension, preeclampsia, or IUGR. But nowadays, it is recommended that low-dose aspirin in the dose of 150 milligram at night is the recommended protocol that is being given up to 32 weeks. Antepartum evaluation. Serial evaluations of fetal growth and assessment of well-being should be done. USG at regular intervals of 3 to 4 weeks for the assessment of piperal diameter, HCAC ratio, fetal weight, amniotic fluid index. Fetal well-being monitored by the daily fetal movement chart or the kick count, the non-stress test, the biophysical profile, amniotic fluid volume, caudal synthesis when indicated for blood gases. Doppler ultrasound measurements parameters are of utmost importance. And the timing of the delivery, important factors that has to be considered: the presence of fetal abnormality, duration of pregnancy, degree of growth restriction, associated complicating factors, degree of fetal compromise, previous obstetric history, and availability of NICU facility. Beyond 37 weeks, delivery should be done. Before 37 weeks, actually beyond 37 weeks, there is no point in waiting mainly because the placenta is also probably grade 3 at that point, and there is no extra benefit that you're going to achieve. So delivery should be done. And before 37 weeks, in uncomplicated mild IUGR, the general treatment is given to improve the general nutrition of the mother and the placental to improve the placental function. Pregnancy may be allowed to continue till at least 37 weeks. And if once lung maturation is achieved, you can terminate the pregnancy. The presence of phosphatidylglycerol and LS ratio, at least 2 from amniotic fluids, is the marker for lung maturity. Lung maturation is not yet achieved, especially in restricted preterm babies. So such babies will require high-level care of NICU. So steroid injections, betamethasone therapy is given if the gestation week is less than 34 weeks. No additional benefit is seen if steroids are given later than 34 weeks. So corticosteroids reduce the risk of neonatal hyaline membrane disease and intraventricular hemorrhage. So the methods of delivery, route and time can be decided considering the severity of the IUGR, maternal condition, and any other associated obstetric complications. Low rupture of membrane followed by oxytocin can be done if the pregnancy is beyond 34 weeks with a favorable cervix and the head is well engaged and deep in the pelvis. So for unfavorable cervix can be primed using cerviprime gel or any other methods of cervical induction can be adopted. Intrapartum monitoring is very, very mandatory, crucial, and it's done by clinical continuous clinical assessment along with continuous electronic monitoring, calf-led sampling when at risk of increased risk of intrapartum asphyxia is high. During the first stage, We have to ensure adequate fetal oxygenation by giving oxygen to the mother using mask. Epidural anesthesia is of choice, and labor carefully monitored, preferably using continuous fetal monitoring measure. So the second stage, the birth should be gently allowed to uh, um, allowed to progress gently and slowly, and avoid rapid compression of the compression and decompression of the fetal head. Episiotomy may be done to minimize the head compression, even though the baby is small. As we know, in asymmetric IUGR, the head may not be that small. So you have to give adequate episiotomy. Tendency to delay the descent is curtailed by using low forceps. Cord is to be clamped immediately at birth. So, management protocol of intrauterine growth restriction to confirm the type of IUGR, to exclude congenital anomalies, to treat specific cause if found, and fetal surveillance is of utmost important, using daily fetal movement count, cardiotocography or NST, biophysical profile, Doppler, ultrasound parameters, and especially ductus venosus, umbilical vein, and MCA. In pregnancy, less than 37 weeks, severe IUGR and mild IUGR. If the pregnancy is more than 37 weeks, immediate delivery. If the pregnancy is less than 37 weeks in severe and mild IUGR, in a well-equipped center, we can, with the fetal surveillance, and if the fetal surveillance pattern is non-reassuring, you have to immediately deliver. If the fetal status is reassuring, we can repeat the Doppler after 1 week. In mild IUGR cases, you can give adequate rest to the mother, increased fluid intake can be advised, and of course folic acid and other nutrients and oxygenation should be checked into. General management should be taken care, and the fetal monitoring should be done till 37 weeks and then deliver in case of mild IUGR. In severe IUGR cases, when there is limited resource facility, it is better to transfer the patient in utero, which means to prompt referral to a highly equipped center without fail, can be detrimental to the babies, to salvaging the baby. So we should not hesitate to promptly refer such babies if we know that our center is not properly equipped to receive such babies. So non-reassuring fetal status, how do we assess? That is, we have to assess the lung maturity using LS ratio, phosphatidylglycerol level through amniocentesis. So if not mature, we can give steroid and deliver. If it is mature, we can deliver. There is no need for steroid therapy. In low birth weight, as per the WHO, the definition, weight less than 2,500 grams, irrespective of the gestational age. And very low birth weight is defined as equal to or less than 1,500. And extremely low birth weight, less than or equal to 1,000 grams. And here I have the chart for the assessing the babies. Large for gestational age, which comes more than the 90th centile, and the small for gestational age comes below the 10th centile. So low birth weight babies, the preterm births occur before completion of 37 weeks of gestation, regardless of the birth weight. The growth potential is normal and appropriate for gestation period in between 10 to 90th centile. In small for gestational age, the birth weight is less than 10 centile or less than 2 standard deviations for the gestational age. SGA babies may be constitutionally small in about 70% or due to pathological process in about 30%. Care of low birth weight babies, the immediate management following birth, cord should be clamped quickly to prevent hypovolemia and development of hyperbilirubinemia. Cord length should be kept at around 10 to 12 centimeters in case there is a need for an exchange transfusion. Air passage should be cleared and promptly cleared of mucus and other amniotic fluid, etc. And gently using the mucus sucker, adequate oxygenation through mask or nasal prongs, nasal catheter is adequate oxygenation should be ensured. Baby should be wrapped with a warm towel, warm sterile towel, and body temperature maintained at about 36.5 to 37.5 degrees Celsius. Vitamin K administration, 1 milligram to be injected IM to prevent hemorrhagic manifestations. And there is an intensive care protocol that's being done. So special care, those intensive protocol requiring babies should be categorized. So such babies who have the inability to suckle at the breast and to swallow, incapacity to regulate the temperature within the limited range of 35.6 to 37.2. That is inability to maintain adequate proper body temperature, or inability to control cardiorespiratory function without cyanotic attacks. So such babies require intensive therapy. So respiratory support is usually given to tide over initial cyanotic phase, and after the air passage is cleared, baby is placed in the incubator with oxygen given, and using nasal prongs or CPAP or whatever. And some babies may even require endotracheal intubation and mechanical ventilation, ventilatory support. Infections are taken care of. Respiratory infection, GIT, skin, umbilical infections need to be checked into. Poor defensive power of the neonates with low immunity, as shown by low WBC count, poor phagocytic activity. Such babies are more vulnerable for infections. Prophylactic antibiotic therapy in premature rupture of membranes is advocated. Every precaution to prevent infections should be taken. Ampicillin 100 milligram per kg per day, or amikacin 10 to 15 milligram per kg per day IV into divided doses for 5 to 7 days given. Favorable signs of progress. Babies admitted to NICU is the color of skin which remains pink all the time, smooth and regular breathing. Babies are happy and stable. They show increased vigor, movements of limbs, and prompt good cry. Progressive gain of weight. That is actually there is a loss of 1 to 2% in the first week, and about 1 to 1.5% regain by the next following 2 weeks. So the initial week there is loss, and the following 2 weeks, there is a gain of about 1 to 1.5%. So considering the discharge, timing of discharge, when they attain sufficient weight, attain good vigor, are able to suck properly, suck at the breast. So the mother is, there are lactation nurses assigned to the labor wards usually, who teaches the mother the art of breastfeeding and how to suckle her baby, and about the feeding schedule. Suitable multivitamin and oral iron preparations are prescribed to the mother and the baby, and attend child welfare clinic for subsequent checkups, immunization, and guidance, especially for contraceptive advice, and supervision continued at home by a public health nurse or other ANMs and other health visitors. And I'm sure the ANMs in our state are doing a marvelous job. So with that, I thank you very much for the patient listening for this topic on intrauterine growth restriction. And I hope that we have some such babies earlier, so that such babies can be salvaged and treated well. Thank you. Have a peaceful night.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, ma'am, to check if any question is.
Okay.
Madam, one question is, am I audible, madam? Hello?
Yes.
Yes, am I audible, ma'am? Hello.
Yes. Hello.
Madam, one question is, what could be the causes of intrauterine growth restriction of fetus in uncontrolled pre-existing diabetes mellitus?
In uncontrolled?
Pre-existing diabetes.
Pre-existing diabetes.
Yes, diabetes.
Along with diabetes, the mother has all associated other maternal health issues like pregnancy-induced hypertension, renal problems, cardiac problems. Everything can be there for such mothers. Mothers with diabetes, such mothers are called as diabetes complicating pregnancy. They are not gestational diabetics. So mothers with diabetes mellitus detected earlier, even during the early pregnancies or early prior to 20 weeks of gestation, are usually termed as diabetes complicating pregnancy, because they might have this problem even prior to conception. So such mothers are more probable for having maternal complications like pregnancy, preeclampsia, pregnancy-induced hypertension, thyroid problems, anemia, all those things. Even renal.
Thank you. Yes, madam. That means preeclampsia also can lead to this.
All these are factors which cause placental insufficiency.
Yes. So, ma'am, in the case of this preeclampsia, as you rightly mentioned, so what will be the precautionary management to that particular, to reduce these chances of IUGR, or is there any precautionary measures to take care of that?
Yeah, of course. When such a mother is detected, as I mentioned, what we have to do is we have to ensure that proper placental blood flow is established or maintained. So meticulous ultrasound monitoring to detect any probability of placental insufficiency to be detected at the earliest. So that is why we say we have to go for growth scans every 3 weeks in such mothers, according to the severity of the problem. And low dose aspirin started earlier. See, for example, in the NT scan or the 3rd month scan, which is the first anomaly scan, when they do the Doppler, they even give you the prediction for preeclampsia at that point. So if you start such a patient, if there is a Doppler abnormality of the Doppler shows that there is a probability of preeclampsia, we can start the patient on low dose aspirin at that very early point of pregnancy in order to prevent placental insufficiency getting to a later stage.
Thank you. Thank you very much, ma'am.
Am I clear on that?
Yeah, sure. Yeah. So, ma'am, I could not find any other question. So, if you allow me, then we can conclude this session.
Well, I hope it was fruitful.
Yes, obviously, madam, it was a great learning to all the participants also. And thank you very much, madam, once again for your valuable time in our platform. And in future also, we will look forward for some some important topic.
You're most welcome. Thank you.
Thank you so much, ma'am, for your
Thank you.
successful first presentation with the Shield Connect.
Thank you.
Yeah, we'll hope to have more and more presentations like this.
Thank you.
Yeah.
My pleasure. Yeah.
Thank you. Thank you very much, ma'am. Have a good night.
night.
Thank you, madam.
Thank you.